Yes.
Good evening, respected seniors and my dear friends. Myself, Dr. Aditya Shete. I'm a junior resident, year 3 at Apex Hospital, Varanasi. So, a warm welcome to everyone on the academic platform Onco Ocean. Onco Ocean, we are striving to provide together, get together like all the academic experts from the oncology field to provide guidance to the residents and compiling all the important topics or aspects in radiation oncology as per the curriculum of MD or D.N.B exams. Today marks session 3 of our module first, that is carcinoma breast, and will be dedicated to the topic role of radiation therapy in the management of carcinoma breast, highlighting its evolution, newer techniques developed, and fractionation strategies adopted. So today's session will be chaired by a renowned faculty in radiation oncology, Dr. Radha Rani Ghosh, ma'am. Welcome, ma'am. Dr. Radha Rani ma'am is HOD at Regional Cancer Center, Kamla Nehru Hospital. Ma'am has authored many publications in national and international journals and has received many number of awards, some of them including Dr. Lachman's Cancer Awareness and Research Award, Dr. B.N. Lal Oration Award, Rashtriya Gaurav Award, IAAC Traveling Fellowship in 2014. And ma'am has special areas of interest in gynecological cancers and brachytherapy. Welcome, ma'am.
Thank you, Dr. Adit. I am really privileged and being able to be a part of this breast cancer conclave. It's really interesting. And thanks to Apex Super Speciality Hospital for creating this platform for sharing our experiences and also a good learning platform for all the students. So a great effort, which is very laudable. Thanks to Dr. Ankita and her team. Um, we are highly privileged today to have Dr. Vineeta Goel as a esteemed speaker today. Dr. Vineeta Goel is Senior Director and Head Radiation Oncology, Fortis Hospital. She has a vast experience as a radiation oncologist of 22 years, and she is she has many fellowships and she has many publications to her, credit. And it will be really interesting to hear her talk. And she's going to speak on the history of radiation in breast cancer, the hypofractionation that we are talking about so much, and the routine, the general fractionation schedule that we were practicing and how we, adapted to the hyperfractionation. So it is going to be a very interesting topic and a very interesting talk by a very esteemed speaker. I request Dr. Vineeta to share her presentation and to proceed with her presentation. Dr. Vineeta, please. It's our privilege entirely to be having you as our speaker. Dr. Vineeta.
So, thank you, Dr. Radha Rani Ghosh. I hope I am audible.
Yes,
Can you
ma'am.
hear me?
Sure,
Oh,
ma'am.
okay. So, thank you, ma'am, for a very nice introduction. And my gratitude towards Apex Super Speciality Hospital and its team, including Dr. Ankita, for giving this opportunity. So, I'll try and talk about strategies of radiation therapy in breast cancer. I'll talk a bit about past because it is said that a wise man or woman should certainly know about past so that the present and the future can be appreciated. So we all know that in 1895, William Röntgen discovered X-rays. It took no time for the X-rays being used for the treatment of breast cancer. 1896, there is a first case report where Grube, who was a manufacturer of Crookes cathode X-ray tube, used radiation therapy for a patient with locally advanced breast cancer. So the history is really long back. Almost a century ago in 1920, there's a first report of radium being used following conservative surgery by a surgeon called Geoffrey Keynes in London. He compared the use of radium needles along with conservative surgery with Halsted mastectomy, and he wrote that unnecessary drastic operations are thereby eliminated, and to many women, the saving of the breast is of the greatest psychological significance. So the potential of Potential of radiation therapy for breast cancer treatment was realized quite early, almost a century ago. Now, if you look at 1950s and 60s, it was not very clear as to what are the indications of radiation therapy. So generally, radiation therapy was given after a case-based, case-to-case discussion. Just give me 1 minute. So the indications of radiation therapy, margins, volumes, doses, all these things were not clear in 1950s and 60s. So in 1950s, there is a report of 200 patients who were treated with mastectomy, and radiation therapy was given one-on-one case basis, generally after discussion with the operating surgeon. So the indications were not very well defined. And radiation therapy alone was used for medically inoperable patients. Even radiation volumes were not clear. There is a series of 250 patients which was published in 1963 where patients underwent mastectomy and radiation therapy was given only to internal memory lymph nodes, high apical axillary and supraclavicular lymph nodes, while radiation therapy was not given to the chest and undissected axilla. And 90% patients landed up with recurrence in chest hole. In that time, radiation therapy was given using ortho or low kilovoltage with little penetration, high bone dose relative to the soft tissue. So there were a lot of toxicities like ulceration, fibrosis, tissue atrophy, fractures, lymphedema, and often need for palliative mastectomy once radiation therapy was given. Late 1960s saw development of mega voltage radiation in the form of telecobalt, Van de Graaff generators, and linear accelerators. So by 1970s and 80s, the indications of postoperative radiation therapy started taking some shape. So people realized that if there are positive axillary lymph nodes, incomplete axillary dissection, large tumor of more than 5 centimeter, skin or deep fascia invasion, then these probably patients benefit from postoperative radiation therapy. It was in 1972 that Fletcher gave this concept of total dose of 45 to 50 gray required to control the subclinical disease in 90% patients. So the dose also started getting slightly defined. In 1971, Fisher published first NSABP study where he showed that improvement in the local regional control with post-mastectomy radiation therapy without any impact on survival. But by 1970s and 80s, the chemotherapy emerged. And there was again a trend towards decline in the use of radiation therapy, more so because people were worried about the side effects of radiation therapy. Toxicity of radiation therapy also decreased with the use of telecobalt and linear accelerator. Internal memory lymph node radiation, I would say, has always been a bone of contention. It was always considered as a potential century for occult disease, and it could cause, which could later on lead to local as well as distant failure. There were surgeons who were very radical in their approach, and they used to do extended radical mastectomy, including resection of the internal memory lymph nodes. There were surgeons who would consider that radiation therapy was an alternative to avoid this invasive surgery. So in 1961, there is a case report where Gutman reported improvement in survival with radiation therapy given for patients with internal memory lymph nodes. 1968, Fletcher reported using parasternal lymphatics. When we were doing post-graduation, we were told that if there is any parasternal swelling, then it is because of internal memory lymph nodes, because in those times, we were not doing CT scans, MRIs, or the PET scan was certainly not there for these patients. So Fletcher reported treating parasternal lymphatics by using telecesium and telecobalt. Now, this all we could do, it could be done in 1960s and 70s because mecha voltage radiation could deliver radiation doses to more depth with skin sparing, but still there were issues of pneumonitis, pulmonary fibrosis, and rib fractures. There were surgeons who persisted with internal memory lymph node dissection, so the debate and the tussle, continued. Now, in the radiation planning and coverage, so we all take so much of pride in saying that we do CT-based planning. So what? 45 years back, also 1979, people thought that they should use CT scan. So it was always thought of. There are also reports of using electrons for internal memory lymph node radiation to reduce the dose to the lung as well as to the pericardium long time back. Now, how breast conservation surgery emerged is also very interesting. So the primary force behind development of breast conservation surgery were women themselves. initially, it was not promoted by the medical or scientific journal. It was rather promoted by the media and lay publications like Vogue rather than the medical fraternity. So there is a comment which was published in 1971 by Joseph Farrow, who was a surgical oncologist surgeon. He wrote, to resist the standard radical mastectomy and to preserve their feminine appearance in a bosom-oriented society. Well, he wrote a very critical remark saying that, for curing breast cancer, mastectomy is so essential that why are we even thinking or talking about doing a breast conservation surgery? So we have to understand that, there was a lot of reservation and resistance for the development of breast conservation surgery. And this is the first report in 1971, which was published. This case series had 77 women. These were women who refused mastectomy or were medically inoperable, and they were treated with incisional or excisional biopsy of the tumor, followed by radiation therapy to breast, supraclavicular fossa, and axillary lymph nodes to the dose of 60 to 70 gray. And in this paper, they showed that outcome was better for patients who underwent excisional biopsy, not incisional biopsy, and radiation therapy was more than 60 gray. So then, gradually people started realizing that, it was possible to conserve the breast along with radiation therapy, along with surgery, and still, give these women a chance of cure. And then emerged these 6 randomized trials. These randomized trials are excuse me, am I audible?
Yes, ma'am, you're audible.
Yes,
Okay.
yes,
Yes,
audible.
madam, you are.
Thank you. Thank you. So then emerged these 6 randomized trials. Now there is a 20-year results of these randomized trials, which is available. You can see the time period. They were done in 70s and 80s. So now there is a 20-year follow-up for all these trials, and they clearly showed that when breast conservation surgery and radiation were given together, then the local control rates or the local recurrence rates were comparable with mastectomy, and the survival was also similar. So one could conserve the breast, women could preserve their breast without compromising on control rate and survival. But you know how surgeons are, they got more confident. They said, why are we giving radiation therapy once the margins are clear? So then there were series of trials, where patients were randomized to breast conservation surgery alone. People said, we will do quadrantectomy, we will take wider margins, but avoid radiation therapy. So they randomized patients into breast conservation surgery alone versus breast conservation surgery plus radiation therapy. And it was clear unanimously across all these studies that breast conservation surgery, when combined with radiation therapy, reduced recurrences far below as compared to surgery alone. For example, if you look at this Ontario study, 35% local recurrence versus 11% when radiation therapy was given. So it kind of got established that whenever one is doing breast conservation surgery, radiation therapy has to be given. Now, in those era, for the students, I'm saying that if you say that after breast conservation surgery, what was the local recurrence rate? It was still around 8 to 10% along with radiation therapy, but now it has reduced to 2 to 4%, and there are several reasons for this. One is that there is improved quality of the imaging, mammograms, MRI, etc. There are improved pathological techniques, better surgeries, better understanding of radiation therapy. They have all contributed to further reduction in the local recurrence rate. Radiation therapy was always looked at as a local treatment, and it was always said that radiation only improves the local recurrence while it has no impact on survival. We have a competition with our medical oncology colleagues because they say that their drugs improve the survival. And then came EBCTCG meta-analysis in 2005, which showed that for every 4 loco-regional recurrences prevented, it translated into 1 additional survival. It takes time for the mature survival rates to show. With a long-term follow-up, it was shown. In 2011 came another EBCTCG meta-analysis, which said that radiation therapy reduced any first recurrence by 50% and improves the long-term survival. For example, look at it here. So this first survival curve is showing any first recurrence. So BCS alone, 25.6%, and with breast conservation and radiation therapy combined at 5 years, it was 12.6%. Similarly, any breast cancer death, it was higher in the arm receiving only surgery. Any death, higher in the arm receiving only surgery and lesser with radiation therapy. So radiation therapy, although it is a local treatment, not only improves the local regional control, also translates into improvement in the survival of these patients. And this is what we have to continuously highlight and understand and emphasize to our surgical and medical oncology colleagues. Let's understand a bit about how the techniques of radiation therapy evolved. So radiation therapy planning was initially done manually. So what? Even the surgeons used to use the scalpel and the knives to operate and would do a hand sew and suturing. Now they use staplers or cauteries. Initially, they did not have that. So even we radiation oncologists used to do a lot of planning clinically, and it was based on bony landmarks and a basic understanding of the anatomy of the breast and the parasternal lymphatics and the supraclavicular fossa and the field size and the interfield separation or depth of prescription. We used to measure everything manually using scales. Doses were also manually calculated using tables of percentage depth dose and etc. Bolus was not required in those times when we were treating the patients on telecobalt, because the Dmax of the cobalt is at 0.5 centimeter below the skin surface, and for telecesium it was only 0.2 centimeter. So we were not using bolus for chest wall in those times. There was generally a library of manually created plans which we would sometimes look at and compare and choose a suitable wedge for our patient. Generally, we would do these kind of marking on the patient's skin and in the center of the field. For example, if this is the field for medial and lateral tangential for breast treatment, then at the center of the field, we would take contours and do manual isodose plotting. There was no record or calculation of dose to the lung and the heart. These were our tools. I remember when I joined my post graduation, Dr. S.K. Srivastav, he used to be the head of the department in radiation oncology. He gave me these marker pens and scale. These were our tools. Gradually, this is a very interesting diagram which Dr. Rajiv Sareen had once shared with me, where he has talked about post-mastectomy radiation therapy 2D planning, where he says that for chest wall tangentials, medial tangential is usually the field is kept at the midline or 1 to 2 centimeter across midline to cover the scar in LABC or patients with medial quadrant tumors. Lateral border is kept at the mid-axillary line. Inferior border is 1 to 2 centimeter below the opposite breast, and the cranial border is kept at the infraclavicular junction. And similarly, a supraclavicular field is marked. Generally, a gap of 0.5 centimeter was kept to avoid overdose or hotspot in the area between the supraclavicular and the chest field. Now, when we were doing all these manual calculations using one medial tangential, one lateral tangential, breast is not a uniform tissue. Breast has a certain shape, ellipsoid shape. So then there was a lot of dose inhomogeneity. So you see, the tissue is less here, the tissue is more here. So this area would get a higher dose. So the dose inhomogeneity was very high. Still, the patients were getting cured. Let's not underestimate. And still, their survivals were improving. I wanted to show this picture of telecesium unit. I have worked on telecesium unit. It's a very basic unit, still very useful in those times because cesium has a very long half-life. So this machine had to be operated from inside, and most of the things were done manually. It was a very superficial dose that we could give to a lot of tumors. Largely by 60s and 70s, radiation therapy to the breast and chest wall was given in telecobalt. For people who have not worked on telecobalt, you have to know that there is something which is used on telecobalt, which is called as breast cone. Breast cone looks like this. So breast cone is actually a half beam block. So what happens is, and there is a rod attached to the breast cone. This breast cone is mounted on the telecobalt machine head. Here it is mounted on this tray. So this has a long arm which helps us set the correct source to surface distance. SSD, as we used to call it, 80 centimeter SSD had to be set. Now in oblique direction, it is very difficult to see the ODI or do it with the lasers. So this length was such that once the perspex sheet attached to this rod is touching the patient surface, we knew that SSD is 80 centimeters, so it would help in the patient setup. The other advantage was that half of the beam is blocked here. So the beam is blocked from the central axis. So that we could avoid the divergent dose going to the lung and reduce the dose to lung as well as heart. Then this perspex sheet, which touches patient's body surface area, once the gamma rays are striking this perspex sheet, it would lead to generation of electrons, which would increase the skin dose. And that is why this breast cone was considered very useful when the patients were treated with telecobalt. In those times, patients often used to have wet desquamation, and hours were spent doing their dressing, cleaning, etc. The patients used to get admitted in the wards. They were kept under reverse cradle for the dressing, sometimes for long time also. Gradually, from clinical planning, we moved to X-ray based planning. We started having X-ray based simulators. So we would position the patient, mark the medial tangential field, lateral tangential field, and would capture the X-ray. And in those X-rays, we would try to see how much is the central lung distance which was coming, whether there was a flash of air beyond the a flash of field in the air beyond the breast tissue, etc., or not. Again, we would take the contours at the mid level, plot those contours. They were very primitive kind of 2D planning systems. We would try and fit in a lot of wedges and see how the dose distribution was coming. Sometimes we would use 15-degree, 30-degree, or 45-degree wedges. These wedges, you have to understand, they are acting as tissue compensators. You see, the tissue is less here on the top, while the tissue is more broad here. So if this one beam is going from here to here, and the other beam is coming from lateral side, this tissue would get overdosed. Now, to avoid the overdosage here, to reduce the inhomogeneities, we would use the wedges as tissue compensator in these patients. Gradually, as the years passed, we moved from X-ray based planning to CT based planning. So we started taking CT scan of these patients in the treatment position and started contouring. Around 2010, there were a lot of guidelines which were published, RTOG, RADCOMP, ESTRO guidelines. We will be talking about contouring in the subsequent class, but just wanted to highlight that there were a lot of discrepancies also in between these guidelines. See, these guidelines were proposed by very senior radiation oncologists who were doing a lot of breast radiation therapy, keeping in mind how these patients were treated conventionally. They gave some guidelines for CT-based contouring. So there were often discrepancies in these guidelines. As the time passed by, we started getting better guidelines which were based on patterns of failure. These were not based on bony landmarks or the interpretation of how the patients were treated conventionally. For example, I would urge everyone to read this very interesting paper by Virgo and Berival et al. This comes from University of Pittsburgh, where they mapped 278 chest wall recurrences from 5 retrospective series. So what they did was they created they reconstructed a chest wall. They made a diagram of the chest wall. So this represents the ribs, this represents pectoralis minor, this represents pectoralis major, and this is skin and subcutaneous tissue. So when they looked at the 278 chest wall recurrences, they mapped as to where the recurrences were happening. So in the Harvard series, 100% of the recurrences were in the skin and subcutaneous tissue. MD Anderson, again, 93% of the recurrences were in the skin and subcutaneous tissue anterior to pectoralis major. So they concluded that most common site of chest wall recurrence following mastectomy was skin and subcutaneous tissue anterior to pectoralis muscle, which was seen in 72 to 100% of the patients. And the second most common site was pectoralis muscle, and none of the recurrences occurred in the intercostal muscles and the ribs. So again, a new guideline came as to how chest wall has to be contoured. So I think this is how contouring guidelines have gradually evolved. At the same time, when these guidelines were evolving, apart from the CT simulator, we also there was a lot of improvement in the hardware and software of the linear accelerators. We started getting multi-leaf collimators. Treatment planning systems became stronger. So we entered into the era of 3D CRT, IMRT, and IGRT. And then there was another debate as to how to do these IMRTs, because the fear was that in case there is a lot of low dose spillage while doing IMRT, these patients would become more prone to second malignancies because of the IMRT. However, we also started with the advent of these planning systems. We started calculating the doses to the lung as well as the heart and started working towards reducing these doses to reduce the risk of pulmonary fibrosis, pneumonitis, as well as cardiac events. At the same time, it was realized that because there was a all-round improvement in the treatment of breast cancer, better surgeries, better chemotherapies, better radiation therapy, people realized that breast cancer survivals were increasing. UK is expected to have 1.7 million survivors by the year 2040. So, and people realized that the benefits of radiation therapy in breast cancer were getting compromised because of increase in the non-breast cancer related deaths, and majority of which were cardiac in origin. So it was highlighted as the key survivorship issue. Then came in 2013 a very seminal paper by Sarah Derby, where she did a population-based study of major coronary events, and she took a data of close to 2,000 women who underwent radiation therapy for breast cancer, and she found that the rate of major coronary events increased by 7.4% for each 1 gray increase in the mean heart dose. We still do not know what is the lowest or what is the safest dose below which there will be no cardiac events. But we know that, when you're stepping up your mean heart dose from 3 gray to 4 gray, then there is a 7.4% increase in the risk of major coronary events. This paper also showed that a majority of these events were occurring at a later time point. 44% events occurred in the first 10 years, 33% in 10 to 19 years, and 23% as late as 20 years. This paper also showed that what were the risk factors for major coronary events. So left breast cancer, especially when internal memory radiation therapy is being planned, was considered as the prominent risk factor. Women who previously had a history of coronary artery disease had a 6 times higher risk. Patients who were diabetic, and let me remind you that we have a growing population of diabetics, patients who had COPD, patients who had high BMI, patients who were smokers, these patients had a further high risk. Now, since this was a retrospective study, there are several limitations, to this retrospective analysis. However, it still showed that any reduction in the cardiac doses is likely to give benefit to the patients. So with this, radiation oncology community started working towards cardiac sparing breast radiation therapy. Now, cardiac sparing breast radiation therapy can be broadly divided into two categories. One is a non-motion management strategy, which could be use of cardiac shielding block or MLC, or positioning of the patient. For example, here you can see in this picture that this lady is positioned prone. So once the CT scan is taken, you can see that the breast falls away from the chest wall, and the better cardiac sparing can be achieved. So positioning of the patient was attempted, prone, lateral, decubitus. It is still being practiced, prone is quite often practiced, especially in patients who have pendulous breast, where you have to treat breast alone. You cannot do supraclavicular fossa radiation or IMC radiation very nicely in a prone position. And I don't find it very useful when we are treating very medially placed tumors also, because medially your dosage sometimes tend to get little compromised. Another challenge that I find in treating patients prone is that majority patients who have pendulous breast, where we try to position them prone, because if the breast is very small, then it will not fall so much away from the chest wall. So it is largely done for patients who have pendulous breast. The challenge is that majority of these women who have pendulous breast also have a high BMI, which means these are women who are little obese. So positioning becomes challenging. There are a lot of rotational shifts when you position these patients. So, one has to put a lot of thought and practice before implementing it. The other idea of doing non-motion management strategy for cardiac sparing is do partial breast radiation therapy. For example, you can do interstitial brachytherapy, APBI, or use of IMRT for cardiac sparing, or use of proton beam therapy. So these are non-motion management based strategies for cardiac sparing. At the same time, there are motion management based radiation therapy strategies also. We started with gating based radiation therapy and have now gradually moved to deep inspiratory breath hold based radiation therapy. In gating, what we used to do was that patient would breathe normally and radiation beam would be intermittently on only when the patient was in that stable phase of breathing or deep inspiration. But then it will take long time. A patient would end up spending 1 hour, 1.5 hours on the couch while being treated with gated radiation therapy. Deep inspiratory breath hold technique is a much more efficient technique and has completely replaced breast gating. So here patients are coached to take deep breath and hold the breath in inspiration for 15 to 20 seconds. Breath holding increases the distance between the heart and the target volume, and the beam is on only when the patient is holding their breath in deep inspiration. It is certainly associated with less radiation dose to heart without compromising the coverage of the disease. This is a nice picture which is showing that this is the position of the heart, lung, and breast in the free breathing scan. While if you look at the deep inspiratory breath hold scan, when the patient takes deep inspiration, the lung gets inflated with air so that the heart gets pushed inside and the breast moves outside. So a physical distance is created. This is another CT scan which is showing that this was the position of the heart in free breathing, while with deep inspiration, the diaphragm moves down, the heart moves inwards. So there is a physical separation which is created between lung, heart, as well as breast or oblique the chest wall. Now, there are several studies, number of studies which have clearly shown that using the breath hold based technique, we can easily reduce the cardiac dose by 30 to 60%. So it is a very effective technique. There is also a meta-analysis of DIBH versus free breathing in post-operative radiation therapy for left breast cancer, which included close to 1,000 patients from 12 observational studies. And this clearly showed that implementation of DIBH in left-sided breast cancer reduces the dose to the heart, LAD, as well as left lung without compromising the target coverage. So I would say that development of IMRT is considered as a very major milestone in radiation therapy in 21st century. But my own mind says that breath holding, gating, motion management is another such very important milestone towards precision radiation therapy. Now, there are several techniques by which one can practice deep inspiratory breath hold. And for each technique, there are multiple commercial products available. I would say that suppose you bought your Linux, say 5 years back, and that time you did not purchase the hardware or software which is required for DIBH practice. You can take an add-on now because there are multiple commercial products which are available. So breath holding based techniques can be either based on the spirometric based techniques, which is called as active breathing coordinator or ABC, which is available in Electa. But this ABC is also available by a third party vendor separately also if somebody is looking for it. Varian uses what is called as RPM or real time position management system, or one can do DIBH using surface guided radiation therapy, or in UK they practice laser based voluntary DIBH. So there are several ways of doing it. So I'll show you one picture of ABC and then try to come back to the explanation. So this is the setup which is used for ABC on Electa. So the patient breathes through a mouthpiece. This mouthpiece is attached to the spirometer. Now the patient has to breathe only through the mouth. So that is why nasal cavity is clipped. Patient cannot and should not breathe through the nose. And this patient is wearing a prism glass. So while she's wearing the prism glass, she can see the monitor at her foot end. This is the monitor where she can see her breathing cycle. So she actually gets to see this. I'll just play this video. So this is the normal breathing cycle. This is showing the time. Now the patient has taken a deep breath. She has gone into the green zone. You can see how nicely she's holding her breath. And this is a timer which is showing how many seconds are left before she has to. So the beam is on only when the patient is holding the breath in the green zone. I hope I am able to give you some clarity on how DIBH is done. So patient has a mouthpiece through which she or he breathes. Mouthpiece is attached to the digital spirometer, which records patient's real-time breathing or breathing waveform. Patient's nose is clipped. Patient wears a prismed eyeglass. And once patient is holding the breath to a required threshold, then there is a balloon valve in the spirometer which closes. So this prevents the patient from exhaling. So what I find is that it gives a very predictable and consistent level of chest expansion with each DIBH. Varian has a different system, which is called as RPM system. So in RPM system, I'll just show you the pictures and explain. So in RPM system, there is a camera which is mounted at the end of the couch or it is mounted on the ceiling. And there is a marker box which is kept at patient's near patient's Xiphi sternum. So when the patient takes a deep inspiratory breath hold, then this camera looks at this reflective box marker and generate the respiratory waveform for the patient. Now here the patient is wearing goggles. These goggles help her to visualize her her own These are video goggles, so help her visualize her breathing cycle. So patient voluntary breath holds. There is no mouthpiece. There is no nose clipping here. And patient holds the breath in inspiration. There is an infrared camera, which is mounted on the wall or couch of the treatment unit. There is a marker box with reflective dots, which is placed at the patient's upper abdomen during breathing. IR camera detects the marker box and calculates the position and movement of the thorax. So RPM is actually tracking the external marker as a surrogate for internal movement. There is a third system which has become very popular and people find that it is very effective, which is optical surface image based system or surface guided radiation therapy. The biggest advantage of surface guided radiation therapy is that there is no radiation dose when you're using surface guided, so guided RT. So this is a kind of system which is used. So there are multiple cameras, infrared cameras, which are focused on the patient's skin surface. And, as the patient takes deep inspiratory breath hold, the chest expands. Based on the chest expansion, it creates the respiratory waveform. This can also be used for intrafraction motion verification. There are several of these softwares which are available by the name of Align RT, Vision RT, Catalyst, Identify. So there are several ones which are available, and it is most popularly used, most effectively used for patients who are undergoing breast cancer radiation therapy with DIBH. So I want to give a very clear message that we have to realize that breast cancer patients now have a longer survival. There is a cardiac doses or cardiac morbidity associated with radiation therapy is a real survivorship threat and an issue. We have to do deep inspiratory breath hold technique. All techniques are effective. One can use whatever resources are available, but we must do it for all our patients. Now, let's also talk about who's the right candidate for doing DIBH. We have to remember that it is a patient-driven treatment. Patient has to breath hold. Patient has to effectively, repeatedly hold the breath. So it can only be done for patient who have the ability to understand instructions. They can hold breath reproducibly. These are the patients who are motivated only can do it. Here, I would like to urge and say that don't think that patients who are not very educated cannot do it. Once they understand the importance, once they get motivated, even an uneducated patient can, or lesser educated patient can do it. This is what I find in the practice. You have to spend time with them and make them understand and then do it. So ideally, it should be done for all left-sided breast cancer patients. Some people consider that age less than 60 years is the correct indication because cardiac morbidity is a late side effect. So it's a choice. I would say that any patient, irrespective of laterality, who's planned for internal memory lymph node radiation, preferably should be treated with the DIBH. Patients who are already at high risk of ischemic heart disease, patients who require bilateral breast cancer radiation, or patients who are being considered for re-radiation should also be considered for DIBH to reduce the lung as well as heart doses. Apart from that, there are some absolute indications for doing DIBH kind of treatment, especially patients who have cardiomegaly, where there's an unfavorable cardiac anatomy, for example, cardiomegaly, thighs-like chest, pendulous breast, or tumor location at extreme medial or lateral end in the lower half of the breast. These are the patients who should be considered. Just to show you a few cases, we had this young lady, she was only 32 years old. She was treated for left breast cancer. She was treated with breast conserving surgery, chemo, and radiation therapy. 5 years later, she had bilateral locally advanced breast cancer. She underwent NACT followed by MRM. So the challenge here was that we had to do re-radiation for the left side as well as do bilateral radiation. So we decided to do her treatment with deep inspiratory breath hold so that we could reduce the doses substantially to the lung and the heart. This was another young lady, and she had right breast cancer with a very low level internal memory lymph node. Again, we chose to treat her with cardiac sparing DIBH based technique. This is a very unique case. So this was a young lady, and she had right breast cancer, which was detected in the second trimester of the pregnancy. She took chemotherapy during pregnancy. Then a premature LSCS was done. She had a baby child, girl child. The child is doing well. After delivery, she underwent PET CT scan, which showed that there was a right internal memory lymph node. And then she underwent right MRM. Now, when she came for radiation therapy, initially we did not think that we would do DIBH for her But when we took her scan, we realized that she had gained a lot of weight during pregnancy and which she had not come by the time she came for radiation therapy. Because of that fat, the liver had moved quite cranially. So when we took the first scan and we did planning, we could neither achieve lung doses nor liver doses. That is when we decided to take her up for treat her using DIBH. And you can see that liver moved from here to here when the breath holding was done. So we could achieve both lung doses as well as cardiac doses. I think one has to be very open to use these techniques. And once you start using this technique, you find that it is very useful. Now, there are very good constraints also which are available, and people are talking about cardiac substructure contouring, for example, dose to left ventricle, LAD, etc. We have in our practice not reached there. We still look at the mean heart dose. There are very good cardiac atlases which are available, and we will be talking about these cardiac atlases more when we talk about contouring. So I would say that cardiac sparing breast cancer radiation therapy is the new standard of care and a very valuable addition in breast cancer radiation therapy. It helps us in decreasing the cardiac doses as well as LAD doses significantly. For a select group of patients where there is unfavorable anatomy, for example, this patient had bilateral breast cancer. On one side, it is chest wall. The other side, there is a pendulous breast, or scoliosis, kyphosis, or phthisis kind of chest wall. One can consider IMPT using proton therapy also. So now, after talking a bit about the past and how the techniques have evolved and cardiac sparing breast radiation therapy, I will switch gears here and talk about fractionation. Historically, we have always been taught that breast cancer or any cancer is generally treated with conventionally fractionated radiation therapy with a dose per fraction of 1.8 gray to 2 gray. So for breast cancer, we were treating these patients with 45 to 50 gray over 5 to 5.5 weeks. And when these patients had breast conserving surgery, then after 45 and 25, these patients would get boost for about 7 to 8 fractions, which would extend their treatment to 6 to 6.5 weeks. This is almost 1.5 months, 90 days, 45 days. So it's a long treatment, which is very resource intensive for patients, family members, hospitals, and there were certainly compliance issues. There were a lot of reports that a good majority of women would undergo breast conservation surgery but would not take radiation therapy because it was a long treatment. And then gradually came the era of hypofractionated RT. By hypofractionation, we mean fewer fractions and large dose per fraction as compared to conventionally fractionated RT. For breast cancer, there are two kinds of hypofractionation schemes. One is moderate hypofractionation, which uses the dose per fraction of 2.5 to 5 gray per fraction. And then there is ultra hypofractionation, which uses more than 5 gray per fraction. Now, when we say hypofractionated radiation therapy, it does not mean that we simply accelerate treatment. We calculate the equivalent doses by using the EQD2 formula so that there is an appropriate dose reduction which is made when the dose per fraction is being increased. Hypofractionated breast radiation therapy can be broadly divided into two categories. One is non-accelerated hypofractionation, the other is accelerated hypofractionation. When I go through more slides, I'll once again explain what is the difference between non-accelerated and accelerated hypofractionated RT. Accelerated hypofractionation would include both moderate hypofractionation as well as extreme hypofractionation using APPI. So what is the rationale for using hypofractionation for breast cancer while we do not use it for a lot of other cancers? So generally the alpha by beta for tumors is 8 to 10 gray, it is high, and for normal tissues it is low, 2 to 3 gray. So using smaller fraction of 1.8 gray, 2 gray, it spares normal tissue more than the cancer cells. But breast cancer is an exception. Breast cancer has a low alpha by beta value of 3 to 3.5, suggesting that the use of hypofractionated RT with appropriate dose reduction and shorter treatment will facilitate better tumor control without increasing the toxicity. So I'll show you the evidence for moderately hypofractionated RT. We have to realize that as a community of radiation oncologists, we are very skeptical about changing the dose fractionation, especially in a curative settings, because we know that what we do today can have repercussions many years later in form of late toxicities. So we generally need ample evidence and long follow-up before we shift our practices. We don't shift the practices very easily. So now I'll talk about hypofractionation without acceleration. So first of all, what is the meaning of hypofractionation without acceleration? So hypofractionation without acceleration means that the treatment is given over same overall treatment time duration, which is generally 5 weeks. So let's look at the evidence and then it will become more clear. So the first trial to use the test the hypofractionation without acceleration was the START pilot trial, or it is also called a START P trial, which was done at RMS Royal Marsden Hospital by Yarnold et al. From 1996 to 1998. So they included patients who had early breast cancers, T1 to T3, N0 to N1, all operable patients. More than less than 75 years of age were included. Only patients who had underwent BCS were included. Patients who underwent MRM were not included. Majority patients were node negative. Boost was given. Supraclavicular and axillary regional nodal radiation was done only in 21% of the patients. And radiation therapy was largely by using bilateral tangential fields on 4 to 6 MV Linacs or cobalt 60. So this was the trial schema. There were 1,410 women. Arm A, which was the standard arm, was 1525 over 5 weeks. This is conventionally fractionated RT. There were two test arms, Arm B and Arm C. Arm B patients received 42.9 grain 13 fractions over 5 weeks, which means only 2 fractions or 3 fractions per week were given. So the overall treatment time was 5 weeks. So this is hypofractionation without acceleration. Arm C had a different dose. It had 39 grain 13 fractions, again at 5 weeks using 3 gray per fraction. So now 5-year and 10-year results of START P trial are available. At 10 years, the local recurrence rates were similar across the 3 arms. There was no difference. But when we surprisingly look at 5-year women with no change in the breast appearance, the women with no change in the breast appearance was highest in the arm C, 39 grain 13 fractions. It was even better than the arm A, which was conventionally fractionated RT. After the success and initial results of START P trial, the same investigators did a proper randomized trial, which is called as START trial or UK standardization of breast radiation therapy trial. A similar profile of patients were chosen, T1 to T3, N0 to N1. Same schedules were tested. Majority patients had BCS. Majority patients had small to medium-sized breasts. 2,200 women were randomized again into the similar fractionation arm with the same overall treatment time of 5 weeks, again hypofractionation without acceleration. At 10 years, again, the results showed that there was no difference in the local control rate, irrespective of what dose and fractionation was used. And in fact, it showed that moderate or marked breast induration was least in arm C, which used 39 grain 13 fraction. It was slightly higher in the arm. You can see here the percentage of patients with no change in the breast appearance. It was best in the arm receiving 39 and 13, while the first two arms, which is 1525 and 41.6 grain 13 fractions, were comparable. We also wanted to know about the cardiac and pulmonary safety of hypofractionation. So now the 10-year results have shown that if you look at the ischemic heart disease, there was hardly any incidence. Less than 2% patients had cardiac morbidity, even at long-term follow-up following hypofractionation. So hypofractionation was found to be safe for heart as well as lung. Using this, they also calculated the exact alpha by beta values, and they found that alpha by beta value for local control was 4.1 gray. For any change in the breast appearance, it was 3.6 gray. It was far less than the 10 gray. At the same time, when the hypofractionation without acceleration was being tested, there was another set of trials which was testing hypofractionation with acceleration. So they were using higher dose per fraction, and the treatment also got over in shorter time, 5 weeks versus 3 weeks. So this is a Canadian study, also known as Ontario Clinical Oncology Group study by Wellen et al. Timothy Wellen did the study. He included only patients who had undergone breast conservation surgery, T1, T2, early disease, node negative. Patients were treated with, again, radiation therapy with bilateral tangential fields using 4 to 6 MV Linacs or cobalt 60, 2D radiation therapy. Boost was not given, and regional nodal radiation was not given. Patients who had incomplete axillary clearance, positive or unknown margins, advanced disease, or large breast size with interfield separation of more than 25 centimeter were excluded, and 1,200 women were randomized into two arms, 50-25 over 5 weeks versus what we follow today, 42.5 gray in 16 fractions, dose per fraction of 2.7 gray, and the whole treatment was given on every consecutive days, which means 5 fractions per week, and the treatment would get over in 3 weeks. Now, the 10-year results of this study were published in NEJM in 2010, and it clearly showed that there was no difference in the local regional control rate and cosmetic outcome. Imagine a patient coming for 3 weeks versus 5 weeks, and there is no increase in the toxicity, and the control rates are also similar. So while this was being done in the Canada at the same time, in the UK, the START trialist, they did another study which is called a START B study. This is again hypofractionation with acceleration. 2,200 women were randomized into two arms. Standard arm was 50-25 over 5 weeks, and arm B was 40 grain 15 fractions given 5 days in a week over 3 weeks using 2.66 gray per fraction. Now, this study also showed that in long term, 10-year local recurrence rates were comparable between arm A and arm B. So the doses are quite iso-effective. And it also showed that percentage of women with good cosmesis was higher in the arm receiving hypofractionation, while the ischemic heart disease and symptomatic lung fibrosis was similar. So this is showing the local recurrences. So you can see, irrespective of the fractionation, the local recurrence rates were less. And this is showing the percentage of women with no change in the breast appearance. And here, the 40 gray in 15 fractions did much better as compared to the patients who were receiving 15-25. And so was true for other changes in the breast appearance, like breast shrinkage during radiation, hardness, change in the skin appearance, etc. Everything was shown to be better in the arm receiving 40 gray in 15 fractions as compared to 15-25. And then there are 10-year results, which have also proved that there is a cardiac as well as pulmonary safety in terms of heart disease, rib fractures, or lung fibrosis, irrespective of the fractionation which is used. So I think these are the 4 trials. This is a table which is showing these 4 trials which paved the way for the use of hypofractionation. But if you look at the patient profile, majority of the patients across 4 studies were elderly patients above the age of 50 years. Majority patients did not have mastectomy. Very few patients required nodal radiation therapy, was hardly ever done, and majority separation plannings were done in the 2D era. Now, with this came a Cochrane meta-analysis, which also showed that the local control rate was equally good between conventionally fractionated and moderately hypofractionated RT. But now let's look at some of the modern series of use of hypofractionation. For example, this is a Danish hypo study, which included close to 1,800 patients, 15-25 versus 14-15 over 3 weeks, and they found that everything was similar across the two arms. Americans are a little resistant to change. People don't want to change because breast cancer has a high cure rate. So all these studies which were coming were from Europe and also from Canada. So MD Anderson published its first case series in 2015, which included close to 300 patients. All patients had BCIS. All patients received tumor bed boost. Randomization between 15-25 over 5 weeks versus 42.5 in 16 fractions over 3 weeks. And they found that there were no differences in the local control rate. In fact, the toxicities were less with hypofractionated RT. And that is when gradually the use of hypofractionated RT increased in USA also. They were skeptics. They were skeptics who said that we do not have enough evidence to practice hypofractionation in MRM or in locally advanced breast cancer. And then in 2021 came this paper from China, which included locally advanced breast cancer patients with T3, T4, or N2 disease. 94% patients had stage 3 disease, 820 patients, 15-25 versus 43.5 in 15 fractions over 3 weeks. And all patients received chemotherapy with similar local control, no difference in toxicity. In fact, hypo-RT had lesser toxicity. So now we have evidence to practice hypofractionation even in locally advanced breast cancer patients who have MRM. Then people said, no, but the evidence for using hypofractionation is not there for DCIS patient. But about 2 years back came this paper, which is a multicentric trial, which included patients with high-risk DCIS, again randomized to 15-25 over 5 weeks versus 42.5 in 16 fractions over 3 weeks. And it found that the IBTR rates and the toxicities were similar. So now we again have evidence to practice hypofractionation in DCIS. Then people said, no, but we do not still have the evidence to practice hypofractionation. Radiation oncologists are also resistant to change. So then came this paper, which was recently published in Red Journal, which is about the use of hypofractionated RT in women who undergo immediate autologous breast reconstruction with or without implants. And it also showed that hypofractionated RT was as safe as conventionally fractionated RT, even for women who undergo reconstruction. So as I showed you earlier, this is an old paper from published in 2017 in Red Journal, which looked at the patterns of practice across USA in terms of fractionation. And it showed that hypofractionation gradually increased not only in academic facilities, but across US as a matter of practice. In fact, if you go through the ASTRO guidelines, in 2011, ASTRO guidelines said that hypofractionation should be only used for women who are more than 20 years of age, early stage tumor, no chemotherapy, very homogeneous dose. But in 2018, they gave a revised statement. They said hypofractionation can be used irrespective of the age. So if you tomorrow you're treating a patient who's 30 years old, don't hesitate from using hypofractionated RT. Of course, you have to make sure that you do a good job in terms of radiation planning. Hypofractionation, as per the ASTRO, is recommended for any stage where you intend to treat the whole breast radiation therapy. They say that you should not use it for regional node irradiation. It can be given to patients who are getting chemotherapy. One has to be mindful. One has to be mindful about the hotspots when you're using hypofractionated RT. As far as possible, the Dmax should be kept as less than 110%. Volume receiving 105% should be less than 10 cc. So there are wider patient eligibility criteria for moderately hypofractionated RT in breast cancer. So I would say that moderately hypofractionated RT trials started in 1993 and we are in 2025. And now there is ample long-term evidence to suggest that moderately hypofractionated accelerated RT is safe and effective for breast cancer patients. And my take-home message is that conventionally fractionated radiation therapy is obsolete. Moderately hypofractionated RT is iso-effective for local control rate. It is gentler to normal tissues. It's resource efficient for both patients as well as healthcare. It is the new standard of care for all comers, DCIS or invasive breast cancer, BCS or MRM. We use it for patients who undergo regional nodal irradiation, irrespective of the age, young or old, left or right, irrespective of the breast separation, patients who have connective tissue disorder, unilateral or bilateral radiation, reconstruction or no reconstruction. If I talk about our institutional practice, I would say almost 100% of the patients are treated with moderately hypofractionated RT, including re-radiation sarcoma and phylloids. With this, I will come to another form of hypofractionation, which is ultra hypofractionated RT. In my initial slide of fractionation, I explained that the use of more than 5 Ray per fraction is considered as ultra hypofractionated RT. So it all again started with historical data. So there is a series from France where women who were too frail or who were not able to attend everyday radiation therapy were given bilateral tangential post-mastectomy radiation therapy once weekly, 6.5 Ray per fraction into 5 fractions, say every Saturday, 5 fractions. Now, they were very surprised that the 5-year local progression-free survival in this group was 78%. When they looked at the late effects in breast cancer at 2 years, there were hardly any side effects. And this gradually gave away. And by then, the data for moderately hypofractionated RT had also become mature. IMRT was now available. So then came this trial, which is called as FAST trial. We radiation oncologists are conservative. We tend to be more careful. So when people started testing ultra hypofractionated RT, it started with a trial called FAST trial, which was ultra hypofractionated RT without acceleration. So what does that mean? That means that they had the standard arm was 1525 over 5 weeks, which is then the test arm 1 was 30 gray in 5 fractions over 5 weeks, which means 6 gray per fraction once in a week. So the overall treatment time is same. The arm C was 28.5 gray in 5 fractions, 5.7 gray per fraction once in a week. So this was a multicentric trial, included almost 900 patients, women more than 50 years of age, node negative early breast cancer after BCS. They excluded patients who underwent MRM or required regional nodal radiation therapy, etc. And majority patients had CT-based modern radiation therapy planning. And the primary endpoint was not local controlled. Primary endpoint was change in the photographic appearance of breast at 2 and 5 years. And secondary endpoint was physician assessment of the normal tissue effects and the local control. They found that, you see here, this is a comparison of 50 gray versus 30 gray versus 28.5 gray. They found that all the toxicities were the higher in the arm receiving 15-25 over 5 weeks and were lesser in the arm receiving weekly high dose per fraction. They found that 5-year rate of mild or marked changes in the photographic breast appearance at 2 or 5 years was statistically significantly higher for 30 gray versus 50 gray. So 30 gray was worse than 50 gray, but there was no difference between 28.5 gray versus 50 gray. So 28.5 gray was considered as iso-effective to 50 gray. And when they looked at the 5 and 10-year cumulative incidence of moderate or marked normal tissue effect in breast, they again found that 30 gray was worse than 50 gray, but 28.5 gray and 50 gray were quite similar. So 28.5 gray, as you can see here, 28.5 gray represents this line. This dotted line is similar to 50 gray, while the breast shrinkage was more in the arm receiving 30 gray. So 30 gray in 5 fraction was probably a little higher dose, and 28.5 was considered as an optimal dose. There are strengths of fast forward trial that it is a randomized prospective trial. CT-based planning using 3D CRT and IMRT was done for majority of the patients. Additional boost was not permitted, removing the confounding factor of boost on outcomes. And the changes in the breast appearance was assessed using photographs when assessors were blinded to the treatment allocation. But then there are several limitations also to the study. The sample size calculation did not account for the 3-arm design and was underpowered. And it is more of a dose finding study. So we needed phase 3 trials, and at 5 years, almost 1/3 patients did not have evaluable photographs. So there were limitations to fast trial. However, still I would say that if you have a patient who's too old, too frail, cannot come for radiation therapy, one can easily practice this. And then came the trial, which a lot of centers have already started, practicing, which is called fast forward. It came at the right time, which was the COVID time. In COVID times, we were struggling to treat our patients. And then came this ultra hypofractionated RT with acceleration trial. I'll show you the study design first to explain the design. So the control arm here was 14-15, not 15-25. So by then it was established that 40 gray in 15 fractions over 3 weeks is the standard of care. So there were 2 test arm, test 1 and test 2. Test 1 was 27 gray in 5 fractions over 1 week, 5 fractions, 5 consecutive days, 1 week. The test 2 arm was 26 gray in 5 fractions over 1 week. So the treatment time was shorter. So this was ultra hypofractionation with acceleration. This was a multi-center phase 3 randomized non-inferiority trial from UK. Large number of patients, 4,000 women, very relaxed inclusion criteria. The eligibility was not above 50 years. The eligibility was any age above 18 years, breast BCS or MRM, T1 to T3, N0 or N1. They in fact excluded patients with low risk, for example, patients who were very old, patients who had T1 disease, grade 1, grade 2, N0, ERPR positive, they were actually excluded. So all these patients had CT-based 3D conformal or IMRT planning, and the primary endpoint was IBTR. And second primary endpoint was normal tissue effect as assessed by clinicians, patients, and photographers, all three. So at a median follow-up of 71 months, it showed that IBTR was quite low across all the 3 arms. It was less than 2% and quite comparable across different fractionation. We as physicians are very concerned about breast edema, breast appearance using this hypofractionation, and moderate or marked clinician assessed normal tissue effect was 9.9% in 40 gray arm, 15.4%, little higher in the arm receiving 27 gray in 5 fractions. It was quite comparable in the arm receiving 26 gray in 5 fractions. So this study showed that 26 gray in 5 fractions was comparable to 40 gray in 15 fractions given over 3 weeks versus 1 week. And it was considered safe. So can we say that 26 gray in 5 fraction is a new alternative for all patients? I would say no. We still need longer follow-up for cardiac safety. Breast size is not mentioned. The results may not be applicable to all biological subtypes of breast cancer. For example, TNBC is different, or particularly patients who have very large inflammatory breast cancer or positive lymph nodes. Now here in this study, fast forward, approximately quarter of the patients received boost after BCS, which was 10 grain 5 fractions or 16 grain 8 fractions, which is quite counterintuitive and difficult to understand. While they were giving high dose per fraction to the entire breast, a large volume, the boost was done with conventionally fractionated time. In my mind, I think that shorter duration of radiation therapy has a potential to reduce radiation therapy disparities to all vulnerable population facing racial, ethnic, or socioeconomic disparities. If you're in a COVID pandemic-like situation, old frail patient, we certainly can do it. But data on RNI is still pending. We need more follow-up before putting it in routine clinical practice. So while this is a data from UK, at TMC Kolkata, Hypo-RT adjuvant trial is already running. They've already published their dosimetric data. The local control rate and cosmetic outcome data is still pending. They are testing 40 grain 15 fractions as a standard arm versus 26 grain 5 fractions with a SIB boost of 6 grain per fraction, 30 gray per fraction to the lumpectomy cavity. So what do guidelines say? The guidelines also vary. This is NCCN guidelines. So NCCN guidelines says that the whole breast should receive hypofractionated RT 40 grain, 40 to 42.5 grain, 15 to 16 fractions. Very selected patients you can do 45 and 50.4. For ultra hypofractionated RT, it says 28.5 grain 5 fraction may be considered for selected patients over 50 years of age following BCS with early stage node negative disease, particularly where the boost is not intended. While if you look at the NICE guidelines, RCR guidelines, they say that offer 26 grain 5 fractions over 1 week for whole breast radiation therapy, very strongly supported. Chest wall, very strongly supported. Reconstruction, very strongly supported, although the evidence is lacking. Partial breast radiation, 26 and 5, very strongly supported. The evidence is lacking. 28.5 gray in 5 fractions over 5 weeks instead of 1 week may be considered strongly recommended for patients who have significant comorbidity or are too frail to come daily for radiation therapy. 15 fractions over 3 weeks is currently standard of care for patients who require regional nodal radiation therapy. So there is some disparity, but certainly conventionally fractionated RT is obsolete. So my final message is that moderately hypofractionated RT has safely replaced conventionally fractionated radiation therapy. For ultra hypofractionated RT, we need longer follow-up and more validation before putting it into the routine clinical use. SPRT-based partial breast radiation therapy is likely to be a new paradigm in selected patients. I'll briefly talk about boost to the tumor bed. Students are expected to know this very clearly. Who needs it? What dose? Sequential or SIV? So we all have to know about this randomized trial, EORTC trial by Henry Bartelink, where 5,000 women, large number of women were randomized to breast radiation alone versus breast radiation plus tumor bed boost. And it clearly showed that with the use of boost, there was a significant reduction, absolute reduction in the local recurrence rate. For patients who were less than 40 years of the age, there was a 10% reduction in the local recurrence rate. For patients who were more than 50 years, there was reduction, but the reduction was less. And this trial has a long follow-up of 10 years, which clearly showed that boost radiation therapy improved local regional control without any impact on the survival. There is even a Cochrane meta-analysis of whole breast radiation therapy with or without local boost, including 8,000 women, which also showed that there was an absolute reduction of local recurrence rate by 2.5%. So tumor bed boost is an essential component of breast radiation therapy, but we are talking about shorter overall treatment time. So sometimes women can be given boost simultaneously or concomitantly. Also, we have to remember that boost is definitely recommended for women who are less than 50 years of age, large and high-grade tumors, high Ki-67 index or high-grade tumors, especially ERPR negative tumors or patients where EIC or extensive intraductal component is present. We all have to know about UK import trial. Import here stands for intensity modulated and partial organ radiation therapy. So this is import high trial schema where control arm was 40 grain 15 fractions and a sequential boost of 16 grain 8 fractions was given. But in the test arm, there was a concomitant boost, 40 grain 36 and 15 to the whole breast with 40 and 15 to the tumor bed versus, I'm sorry. 36 grain 15 fraction to the whole breast. The quadrant was getting 40/15, while the tumor bed cavity was getting 48/15. And in test arm 2, there was a dose escalation for the tumor bed boost, and it was given 53 grain 15 fractions. So I think I'll skip all this now because APBI will be covered as a separate topic. And I'll simply come to the conclusion now because it has already been a long talk of more than 1 hour. And I'll come to my last slide and would like to conclude by saying that there are several path-breaking advances in breast cancer radiation therapy, which have all resulted in improved safety and better control rates for our patients. I would say that breast cancer radiation therapy had a glorious past. We are in exciting present times, and we look at for a very promising future. And because of this advancements in technology, so many trials, you can rationalize and individualize radiation therapy for every patient. We've all gone from this journey when we were called as radiotherapists, and now we have a better designation as radiation oncologists. So that this journey has been long and tough, but I would say it has been very rewarding. I think that past was based on real intelligence. I'm in awe of the people who, could do radiation therapy planning based on the clinical landmarks, because those clinical landmarks are still relevant. Even when we do CT-based complex plannings, we find that those landmarks or the guidelines given in that era still hold true. So the past was based on real intelligence. Future is likely to be brighter because we will have real as well as artificial intelligence. With this, I would like to end my talk and conclude by saying that we all have to, this journey was not easy. From radiotherapist to radiation oncologist, now it is upon us that we all should be so knowledgeable and should be able to do good job for our patients, safe job, safe radiation therapy for our patients, so that we, continue to have this kind of admiration and respect from our colleagues, patients. It's not easy to survive in a multidisciplinary, system where you have surgical oncologists, medical oncologists. We all have to be knowledgeable. We all have to have aura of knowledge around us. Only then we will be able to do a good job for our patients. Thank you for your patient hearing and joining us today.
Thanks a lot, ma'am. That was such an interesting, elaborative, and a lucid presentation covering everything from the history to newer techniques and their evidences. I would request Radha Rani, ma'am, like if you want to add something to the talk.
Thank you so much, Dr. Vineeta. Congratulations on such a wonderful talk. You took us through the journey of radiation therapy and breast cancer. Really took me back to the 80s where we used to do all those 2D plannings.
Yes.
And I always tell my students, tell all the aspiring and, the promising radiation oncologists, that being a radiation oncologist at that time, when we did not have so much imaging to help us out, it was difficult. And you rightly said, intelligence at that point of time, because we did the markings based on our surface anatomy and the knowledge. We have so much information now. We have the help of the images, good imaging modalities, and the machines, the computers to help us out. I remember those days when we used to do the manual contouring. So from there on to CT contouring, doing it on the planning system, things have become easier, but become more interesting. Thank you so much for taking us through the journey. And I'm sure all the students must have, gained so much knowledge. You need to know your history first, to know what the present is, and also to know what future holds for you. We might not be there for what the future has in store for us, but you all will see and live the future. So it's been wonderful, madam, for such a wonderful talk. And if the students have any questions, are there any questions in the chat box or something?
Yeah, there's one question. Should we use moderate hypofractionation radiotherapy for patients who also require supraclavicular irradiation as a part of treatment?
So the evidence for using supraclavicular fossa radiation with hypofractionation is there, because if you look at START A, START B trial, where We have long-term results available. There also about 15 to 20% patients did get supraclavicular fossa radiation. I forgot to mention another very important point. John Yarnold, who was the principal investigator behind these STAR trials, was working at PGI Chandigarh for a long time. So when he was there, PGI Chandigarh completely changed its practice even before the results or before actually the starting of the START or Ontario trials. So they have been using 40 grain 15 fractions for many, many years. And PGI Chandigarh is in India. Majority patients were node positive. They were giving supraclavicular fossa radiation also. So initially, I also had some recommendation when I started using moderately hypofractionated RT 14, 15, whether it will be safe for brachial plexus if I give supraclavicular fossa RT. But when I spoke to my friends and colleagues in PGI Chandigarh, they said, we've been doing this for years, donkey years. There is no brachial plexopathy. So I am regularly doing it for patients who have supraclavicular fossa, require supraclavicular fossa radiation or even internal memory node radiation. So it's safe to practice.
I request participants, if like you have any questions, you can post them in the chat box, because so far we have only one question.
I suggest we can have one discussion. I think students, they are a little hesitant also, madam, to come out with questions. So let them think over, go through these trials, what madam has talked about, and then we can have a separate session in this conclave only at the end of it, where you can have madam and we can have a panel discussion sort of a thing, where they can come out with their questions, whatever they have prepared, or you can ask them to, post you the questions, and madam can have another session answering those questions.
Yeah.
There should be so many questions, because madam has covered from radiobiology to fractionation schedules. She has explained it so very well. They will go through the trials, study it. I'm sure there'll be so many questions.
Yeah. There's one question here, like dose constraint differences between chest wall and SCF and without SCF.
So very good, very nice question. That brings me to another point. When you're adding supraclavicular fossa radiation, it does not impact the cardiac doses. It will have little impact on the lung doses. However, the lung constraints will remain same. For brachial plexus, you don't have to put any constraints, except that you have to avoid a lot of hotspot in that area. Initially, we used to contour brachial plexus and ask our physicists to avoid hotspots. Now we stopped doing that also. We generally tell them that the planned Dmax preferably should be less than 110%. But then another organ that we have to think of constraints is esophagus. Today only we had a discussion with Dr. Sushil Beriwal sir, and we often forget to give constraints to the esophagus. Esophagus is a long structure of about 25 centimeter from cricopharynx to GE junction. What we do in our practice is that we create another esophagus structure, which we call as esophagus evaluation, where the length of the esophagus contoured is only till 2 centimeters below the supraclavicular fossa. We generally keep the constraint to this esophagus eval mean dose of less than 12 to 14 gray. There is also a publication from Ohio where they have recommended that the esophagus evaluation should be contoured from cricopharynx to carina, and its mean dose should be kept less than 10 gray. So that this is the only difference in the dose constraints between chest wall plus SCF versus without SCF.
And also, even the participants, if they wish to post any questions, they can post on the YouTube link, because this YouTube video is going to stay there. Like if there are questions, we can ask madam to conduct a different session for that.
Dr. Adi, I have a question for you. The
Okay, ma'am.
YouTube link that you have shared,
Yeah.
how will people search it in future?
No, we've posted in the group also, and we've like when we came up with the channel, we've
Huh.
asked the students to join the channel. Many have subscribed the channel also.
Okay.
Yeah. I think that's all. We don't have any more questions.
Mhm.
So if the speaker and chairperson allows, we can close the session.
Thank you so much.
Thank
Thank
you,
you, madam.
Dr. Adi.
Thank you, Dr. Adi.
Ma'am, there's a question. Just wait. Ma'am, this D mean dose for esophagus is for conventional fractionation or hypofractionation?
Hypofractionation. I'm assuming that all of you will do only hypofractionation.
Exactly. Yes. We already gave a RIP to the RIT to
Yes.
normal fractionation. Yes.
Yeah. So
Thank
on
you.
this note, I would like to thank our chairperson, Dr. Radha Rani ma'am, and our speaker, Dr. Vineeta Goel ma'am, for conducting this session. And I wish all the participants to have more active participation in form of questions or in form of number. We will be having our next session on next Wednesday, and the topics and the speakers will be informed to you through the link.
Thank you.
Okay. Yeah.
And good night.
Thank you and good. Thank you, Aditya.
Yeah.
Thank you, Ankita. Thank you, Dr. Radha Rani, and all the attendees. Thank you.